So what I will do now in my short presentation is just to show you 3 examples of analyzing the ethics behind certain decisions that had to be made in the pandemic situation in Germany, and the advice that we issued to German government and German policymakers. And it will be quite applied. So it will not be quite as fine-grained as what we've just heard in Laura's wonderful presentation, but it will be quite practical and so hopefully interesting as well. I have not put my affiliation as the chair of the Ethics Council very prominently on my slide because I can be a little more open when I speak as a scientist, if you will. Okay, this is something that should not be shown because usually I do a whole thing of what is ethics, blah, blah, blah. I will not be doing this here, of course, in this room, but this is just to show the German Ethics Council. So I will start immediately, skip all the preliminaries and start with the first example. So the first topic, and we've just heard about that a lot, we picked up in our very first ad hoc recommendation in March 2020, is the topic of triage. And we said very clearly that initially there were very few concrete guidelines for true, absolute scarcity, sort of hard triage. As you know, triage is something from catastrophic medicine or battleground medicine. So there are established frameworks for triage, but they usually are for situations of mass casualties over a short period of time and not sort of long drawn out triage where something might have to happen, which is actually stopping treatment of patients in order to give resources to patients with a better outlook, better prognosis. And we analyzed this and said something that is very obvious to everybody here, that a situation such as a pandemic of that kind, which presents drawn out scenarios of incoming very ill patients, overwhelming the healthcare system, requires the extension of the usual ethical focus of clinical practice, which is the individual patient perspective and the principle of beneficence, non-maleficence, and so on. But obviously, in this regard, most importantly, beneficence, which is the optimum treatment of patients towards including, in addition, a more collective public health perspective. So moving away from the solely individual perspective, patient-centered perspective, towards having in mind all the other patients. So obviously the principle of justice coming in here. And we said something quite similar to what we've just heard. We said that we relied on our constitutional framework, and the German constitution does not allow that there are material criteria by the state issued for ranking lives that rely on things like age, gender, the social role, but also, and that might be an issue of contention, the length of life, qualis, dalis, that kind of stuff. We did go into the differences between ex ante triage, which is the classic mass casualty scenario where not everybody can be saved, and simply what is available at that moment right now has to be prioritized. And we said that is horrible, but it's ethically as well as legally speaking the easier scenario, because you simply try and save or use your resources as effectively as you can in that situation. A lot harder and outside the German legal system is the ex post triage, where you are in a situation where everything is already full and constantly patients keep coming in. And we said, and that was quite controversial. Sorry, my presentation is buggy. I don't know what's going on. We said that there should not be material requirements or standards for the latter kind, for ex post triage, issued by the state. We said that is not possible, that the Constitution forbids issuing state rules on which lives need to be saved before others. However, we said there could be subsidiary recommendations if such a tragic situation occurs. So far, knock on wood, we haven't been there yet, but we're very close at the moment. We said subsidiary recommendations can be given to at least ensure reliability, transparency, and a principled approach to that kind of catastrophic situation. And that was issued early on in March by medical professional societies, revised several times, and it has as its main criterion the clinical chance of success, direct chance of survival. So not overall length of life. And that is based on various clinical parameters and scores, and it includes a procedural justice principle, which is distributed decision-making. So it's several people that will carry that particular responsibility. It's very open whether that is legal. And we're discussing this right now at my university hospital, where we operationalize these recommendations. We built them, we're prepared pretty much. And yet it's still very unclear whether anybody who used that, who followed this recommendation, which is now an official guidance by the German medical bodies, would be protected by the law in case they made these decisions or not. So there is still an ongoing discussion whether we need a law. And that would clash with what we have said about the constitutional framework. So very much open. Second topic, lockdown versus opening up society, also something everybody's familiar with, something that is still very relevant. And the main ethical conflict here, we said, was, of course, the protection of life and health of many people, but in particular, the protection of a functioning healthcare system. Because if that is overwhelmed, everybody in a society is affected. That is, constitutionally speaking, the main reason to restrict liberties and to protect against that. However, we were very early on already focusing on the implications of that, the collateral effects of measures against the pandemic for individuals and society, psychological, social, economic, and so on and so on. So we were, in our country at least, probably the first ones to say there is not a clear answer, an easy answer that is not contentious, but this is something that has to be constantly balanced and is a deep ethical conflict. And we said at the time, and we would say this again and have said this, that strong restrictions were justified, currently are justified. Again, our healthcare system is in danger of becoming overwhelmed, but that it doesn't mean, and here's a German quote, forgive me for not translating this, that the protection of life cannot be supreme. Other rights and liberties have to be weighed against this right, and a certain risk has to be accepted by everybody, and Germany is currently struggling to define that level of risk, and I'd be very interested to hear what you think, because we know that is something that societies seem to be doing in a very different fashion. We're very much not in a situation of sort of a certain general risk to life that is similar to anything that we usually accept. One of the examples is other respiratory illnesses that also cost a few thousand lives per year in Germany, for example. That's one of the examples to sort of try and calibrate the acceptable level of risk. We're absolutely not there yet. We just had studies published that show that we had a significantly elevated rate of death in 2020 by at least 5% more. That is a lot. And we're currently also nowhere near that kind of level, just to be very clear about that. But it is a debate that we will be having over the next months, in the next year. And so just to sort of bring this to a close for this topic, that of course involves balancing these two main goods or goals, involves weighing them, struggling to find the right balance. And we suggested that principles such as solidarity play a role, that the most vulnerable might require most protection, that measures at the same time have to be proportionate, that there's always a duty of providing reasons for restrictions. A reminder, this is March 2020, and that has not happened across the entire time, and that there always needs to be sort of a time, an exit strategy, if you will, a time perspective. And this is something that a lot of people don't like when I say that, that overall, therefore, this struggle that we've had in Germany, the back and forth, the how much can we open up, and how can we keep restrictions as small as possible. So we were not a country that did no COVID. And the German Ethics Council did not suggest no COVID. That this sort of, and there's been a lot of debate around that, that this was ethically speaking regarding the process, forgive the typos there, correct and acceptable. And that's very clearly a procedural judgment, not something that says anything about specific individual measures. Finally, we were called upon, together with the National Vaccine Committee and the National Academy of Sciences Leopoldina, to develop a framework for priority setting of vaccines. It was very clear that these were going to be scarce in the beginning, and that therefore priorities had to be set. And because, don't have to say that in this room, but have to explain in others, because very important goods of protection of life, of chances of protection and survival were being allocated or had to be allocated. This could not just be done based on medical principles, but had to include ethical legal principles. So we did that together with these two committees on request by our health minister. And here, just very quickly for you, the relevant ethical and legal principles, autonomy, of course, self-determination. We back then ruled out a general vaccine mandate, did not rule out one for certain professional groups, and are currently revisiting a general mandate, non-maleficence and protection of integrity. That was a lot more important than beneficence, because beneficence looks at the optimum treatment of individual patients, whereas this is a situation of sort of sufficiently good provision to as many as possible. And the non-maleficence principle led us to consider all the risk constellations, who is at what risk of what harm, which groups, da-di-da-di-da. You know, there's a big difference. Used to be, this was the time of alpha and the wild type. So the elderly were at a lot more risk than younger people. Obviously, the principles of justice and equality before the law came in, because everybody has a legitimate claim to protection. But if risks are significantly different, it is, of course, very simple principle of justice, justified to treat these people differently and protect them differently. Principle of solidarity, sort of everybody stepping back from their legitimate claim to a vaccine and protecting those most vulnerable, all that pulled together in the principle of urgency, and then a number of procedural criteria, transparency, constitutionality, and so on. These were the 4 vaccination goals that we developed: prevention of severe causes of COVID-19, hospitalization and death as the main one. Mind, this was before we knew what the vaccines could do. We issued this in early November. So we didn't even know if there was going to be a lowering of the transmission of the virus, which we had, and which sort of is waning, but can be boosted again. And you all know that. That is a moving target. Second, protection of persons with an especially high work-related risk of exposure, sort of occupational indication. Then already, even though we didn't know how transmission would work, definitely the protection in environments with very many vulnerable individuals. You see solidarity peaking up in these two goals 2 and 3. and sort of in situations with a high outbreak potential. We had, for example, the meat industry with huge outbreaks, very, very bad working conditions, and the maintenance of essential state functions and public life. And what we issued were 3 priority groups, the main ones: people with highest risk for severe disease and death. Those are, at that time, by I think a measure of 1,000, elderly people in care homes with the very highest risks. Then those who look after people with the highest risks, healthcare workers, and not all of them, but those at risk, and then essential workers of many kinds at risk of infection. And the Standing Vaccine Committee then took this sort of broad framework and used all the evidence available to get a more fine-grained priority list. And I can say with a certain amount of sort of modest satisfaction that this was one of the rare situations where an ethical framework developed coincided with the main goals that at that time were necessary for curbing the pandemic, which was at that time to prevent deaths and severe causes of illness, which happened. So roughly 30 to 40,000 deaths were avoided by the priority scheme. And it also coincided with public opinion. So German people were polled on this framework, and it way beyond 90% supported this, even though it meant many people that wanted a vaccine very quickly did not get one. So for an ethicist, this was one of these examples that maybe where things didn't go completely badly. And this is just how the process then finished. It was sort of made into the recommendation, the legal provision that was changed a couple of times, but overall, this framework underlined the way it was done in Germany. Their living documents, again, they were revised, and then the priority setting stopped in June when there was enough for everybody. Just sort of some general conclusions that the ethical analysis and debate, hopefully, and particularly if it is done in an interdisciplinary way, pulling in the evidence that's necessary, all the expertises that you need in a situation like that, can provide more transparency for justification and for decision making, and hopefully not just improve public trust, but also policy decisions, hugely relevant in a crisis. Of course, we have an enormous theory-practice divide. Sort of non-ideal theory is not relevant in a situation like that, or only very, very, it is relevant to sort of clear arguments, but then we definitely are in non-ideal situations. And this is something that I keep saying, that ethics can help make things more just. But for real world settings, in particular in tragic situations, so back to the triage situation, it will never yield good or fully just results. It can only sort of do a little bit to make it as good as possible, which can be very frustrating for both theorists and those in practice, but it is still the best option. Responsibility obviously remains with policymakers and decision makers, very important. And as you all know, the immediate challenge is always how to get it implemented, and how can ethical guidance be granular enough that it really can guide practice. It's a steep learning curve. There's a necessity for continuous adjustment, revision, and improvement. So lots to do. Thank you for your attention.
Thank you very much. Excellent. Thank you, Alena. We have some time for questions, and if you want to pose a question, raise your hand and speak into the microphone, or write something in the Q&A and say who you are.
Wow, okay. That's an interesting question. The answer is absolutely not. No way.
Hello, Alena. Christian Munter here from Gothenburg, but also Berlin. So a question to you that I suppose you have on your table right now is, I mean, so you have a really good vaccination coverage in the western part of the country, but the eastern part looks really bad. So how are your discussions going? Because we discussed vaccine mandates and different kinds of policy incentives that you could set up that could appear to be very tough, and you were kind of also worrying about the risks of backlashes, that you were locking people into even more of unwillingness to vaccinate. So how are you thinking about those kinds of things, weighing the principles and the pragmatics?
Excellent, very difficult question. No easy answer, obviously. We don't know why we have this divide. There are lots of theories that it has to do with the experience in a sort of a totalitarian system in the eastern parts of Germany. But then that doesn't explain Bavaria, which also has abysmal or very bad vaccination rates. So there must be other things at play here. One thing that can be said, which makes the discussion about general mandates so frustrating, is that a lot went wrong. Our vaccination campaign wasn't as good as it should have been. There are other examples. We all know Portugal, Denmark, so on. Italy, certainly France, have done things better, and it has unfortunately not been done very well by different layers of German politics, which includes the federal government, but also the Länder, the federal states. So the communication wasn't good, and sort of the infrastructure was lacking. So lots and lots of things. So that's just various explanations. We're currently, I can't say too much about it, but we're currently, of course, discussing exactly what you say. Could mandates reach successfully people that have not been reached yet, or actually sort of force them, if you will, to get the vaccine? That depends on how you design them and how you enforce them. And everybody is in agreement that if you have a vaccine mandate, you must enforce it properly. Otherwise, it doesn't make any sense. Otherwise, it's sort of a toothless instrument that splits your society to some degree and doesn't really yield any results. So if you do it properly. Some say it might have the effect that even people who, and that is, there are historical examples of that it sort of puts a certain peace into these debates, because people can then still disagree and have various different reasons, but for everybody there's the same rule. The way we now have it is you look at your neighbor and you think, why does this idiot not get the vaccine, right? Once you have a rule, you don't have to look at your neighbor, because they are sort of either in agreement or disagreement with the rule, and the rule's the same for everybody, and then they get sort of, they get punished by somebody else and not by your moral judgment. So we have a lot of moralizing going on in debates, and some expect that it might calm down debates if you have a general rule for everybody. And some also say it might be sort of like an excuse for people to get vaccinated who are in situations that are very much against vaccines, sort of gives them a reason, an excuse why they get vaccinated. And again, there are historical precedents for that. But there are also historical precedents that this might radicalize certain groups, and we are certainly seeing that in Germany. It's a very volatile situation, and that it might sort of drive them very deeply into a certain form of illegality. So we're currently weighing this up. I have no fast answer. I'm interested myself to see what will happen. Could I respond to this excellent question in the Q&A about the Menschenwürde, the dignity? Because is that okay?
I'm lost here because I didn't know that you could see the Q&A. So something has happened. But of course, Mikael should post the question or raise the question and you answer it. But how do you see the Q&A? I can't see it.
I see the chat and the Q&A.
Yes,
I'm very privileged.
So
it's German ingenuity. Okay. Mikael.
Yeah, the problem is that all the spectators here in the hall can't see the questions. So I have to read them up and then you can answer them. So the first question is, would you agree with Tenche's suggestion earlier today, which you didn't hear, but you see it here, to fully eliminate the notion of Menschenwürde, dignity, from medical ethics? And do you see any tendencies in Germany to argue for a kind of Swedish socio-engineering utilitarian medicine ethics applying, for example, QALY, etc.?
No, not at all. So thank you for that. That is obviously a question that a German ethicist is very well used to. And I'm socialized in the UK. So I'm very much fond of a pretty pragmatist approach. I have no problems discussing utilitarian approaches. Yet still, I am absolutely not expecting whatsoever that the principle of human dignity will disappear or will that we will become more utilitarian. And the reason for that is that it is the foundation of our constitution. And so there's something interesting. The principle of human dignity is often applied to wrongly and far too broadly. So many things are called sort of violations of human dignity when they are not. And it's often used, we say in Germany, Holzhammer argument, right? It's like a discussion stopper. You pull out human dignity and that's the end of it. And that has stopped in Germany. So if you're familiar with German discussions on bioethics about, 10, 20, 15, or maybe even 25 years ago on stem cell research, embryo research, that kind of stuff, it used to be that way. It used to be, this is a violation of human dignity, and then the discussion was at its end. And that has definitely stopped. There's a much more nuanced understanding of what the principle of human dignity actually entails, which is often framed as it is framed as an individualized approach, but there are also collective understandings of human dignity. So the discussion has improved a lot, and references to human dignity are used a lot more sparingly, also in the German Ethics Council. That, again, used to be very different just 20 years ago. But it is definitely still underlying our constitutional framework, and therefore it will not disappear from medical ethics anytime soon.
Alena, we have a couple more questions here, and not that much time, but can you answer them, give a short answer? But I want to ask the world's last two utilitarians here, Peter Singer and Torbjörn Tenche. You cannot be very happy, and Katrina, with the German Ethics Councils or the approach here. It was actually what you argued against all morning, or am I missing something?
Thank you very much for the opportunity to ask a question. I think you've already dealt with one of the points that I was critical of about the use of human dignity as a kind of absolute block against certain discussions. But I wanted to ask you in relation to what you said about excluding using a variety of criteria, including length of life and quality of life. And I really wondered how hard you were prepared to push that. Because if somebody has, for example, an underlying disease that means that their life expectancy, quite independent of COVID, is relatively short. Let's say they have metastatic cancer. But clinically, that's not going to affect their recovery from COVID. Let's just assume that it's not going to affect their respiratory system, for example. Would you still say that they should have the same priority as somebody who can expect to live 20, 30, 40 years? And similarly, if somebody is very profoundly cognitively impaired, but that has no effect on their life expectancy, would you still put them on a respirator along when somebody else might be denied it because of that?
Quick answer, yes. Personally, I'm very happy to discuss this in a slightly more nuanced way, but the German approach certainly is that just because somebody is cognitively impaired or has a shorter time to live, that doesn't mean that when we compare them to others, their life is worth less. So they need to be considered in the exact same way. We don't maximize life years. And that was implemented in that guidance. As a doctor, which I'm too, I can tell you that these are very theoretical considerations, of course, because both people who are very heavily cognitively impaired usually also have other health issues. Firstly. Secondly, those with metastatic cancer definitely have a lot worse prognosis. So practically speaking, of course, that will affect their chances of being considered in comparison. But if as an independent criterion that doesn't look at the overall clinical situation, the German position here is very, very clear that you can't do that. That said, our documents include the suggestions that people very carefully consider if they still want treatment at all. So sort of the idea of saying, I don't even want to go into hospital and I will sort of forego certain treatments. But if push comes to shove and we are in a situation like that, which might still happen, I will be one of the people leading the ad hoc ethics team in our hospital. So I would be sort of advising on the triage. Then we could not say, well, these people are sort of clinically the same, but one is cognitively impaired and the other isn't. So we'll give it definitely to the person that isn't cognitively impaired. That is not possible based on our guidance. We just had a very contentious discussion if we might consider vaccination status. Again, vaccination status affects your prognosis. So usually people who are vaccinated have a much better prognosis. But what if you have a 30-year-old not vaccinated person and an 80-year-old vaccinated person, and they are clinically speaking equal? Could you then use vaccination status? And that is still open. My own personal suggestion would be that if you have considered the other criteria first, as a secondary criterion, vaccination status as a secondary only might sort of push the scales, because this is not something, and that is different from being cognitively impaired or having a life, a life expectancy that is a lot shorter. That is a voluntary decision. So, I mean, we don't have to go into this desert, personal responsibility, all of that, but I would say that that is a difference. And that likely would also not violate the principle of human dignity, whereas the other situation would be in violation of that principle.
Thank you, Alena. We have two questions. Can we do it this way? You actually had a very short answer, yes. Can you do it the same way here? You get two questions and then you get two answers from you, and it can be yes, 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 no, no, yes, or whatever.
Yeah, so, but only if the question is appropriate then.
Okay.
Appropriate in length or complexity, of course.
Thank you very much for your presentation. It was very interesting. Hans-Ingvar Roth from Stockholm University. In Sweden, of course, we had a lot of discussion concerning that we were not really prepared for a catastrophe like this. And we have discussed also the option of having state of emergency in peacetime. As we know that, well, in Sweden we have state of emergency in war, but we don't have it in peacetime. And that is, of course, an issue in the light of this pandemic. France has it, but they also have state of emergency in peacetime. But given the past or the historical experiences of Germany, have you have not discussed that question to introduce state of emergency in peacetime? Also given the experiences during the 1930s, for example.
Should I answer directly?
I think we do it that way. That's the best way.
Very quick answer.
Yes.
One of the first questions I haven't heard across this entire time, and we, as far as I know, but I don't actually know for certain, we don't have an emergency or a state of emergency, state of catastrophe in peace times, but the federal states have it. Some federal states did that. So we do have it in some federal states. I don't know if we have it for Germany. That was never discussed. I have never seen any public or even internal debate on that. Thank you very much for that question, because I'll find out. That's really interesting. I don't know.
Thank you very much. I'm afraid this question might not be a yes/no answer to. When human dignity is not used as a discussion blocker, how is it cashed out? If you could tell me a bit more. Is it equal treatment, something else? And secondly, is there a discussion in Germany, a difference from the Constitutional Court as we heard, that where when different people's dignity is at stake, that you can do some kind of comparison, that you go for kind of minimizing violating people's human dignity, or is it just a stop? I'm thinking about this case about shooting down planes, and you're not allowed to do that because even though many more people will be killed and things like that.
Yes, thank you. I won't go into that case. The short question to your second, the short answer to your second question is yes, you can do that, and it is being done. And I think that case would likely today be discussed in a slightly different way. The first is that the way it's operationalized is that there needs to be equal consideration for every person's worth. So there are certain characteristics, such as their cognitive capabilities or their length of life, do not figure. They might figure as secondary and tertiary considerations, but certainly not when they're when life is put against life. The case of the plane is sort of the Torek discussion, right? Can one person's consideration of their worth trump, practically speaking, the consideration for their lives of 100 other people? And that decision stunned many. I think that was a wrong one, by the way. So I would not consider it that way. I do believe there is also, in terms of the principle of human dignity, an opportunity to look at collective forms of human dignity, so that we can have a certain additive element in there. But the main question when we talk triage, and when we talk triage in a pandemic, is still one patient against the other, and not 150 people against one patient. It's a clinical situation. And so there we said very clearly, because we're considering each person equally worthy of having their life saved, these characteristics cannot play a role. They have to be clinical. They have to be sort of related to, will they survive this treatment directly or not, irrespective of their life expectancy in the long term.
I think I have to stop the discussion now. Thank you very much, Alena. And it's sad that you can't participate in the panel discussion this afternoon, but I know you have important work to do, so good luck with that. And thank you very much.
Thank you for the discussion.